The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. This is Emily Isaacs, the program manager for the New York PASRR program at Ascend. We want to thank you all for joining us this evening. Suzanne de Beaumont from Open Doors program has been gracious enough to offer us the opportunity to learn a little bit about their program and how it goes hand in hand with PASRR. So she'll be talking a little bit about what they do. And so just to give you a little bit of context from our perspective for our assessors that are here tonight, the way that it really goes hand in hand with PASRR is that if we do an assessment on an individual that is a current nursing facility resident and we believe that their needs could be met in a less restrictive environment, we might make a recommendation for that person to be referred to Open Doors. As you'll learn tonight, they're great in terms of coordinating, linking that person to community resources. So again, thank you all for joining tonight, and I'm going to turn it over to Suzanne.
Hello, everyone. So again, my name is Suzanne de Beaumont. I work for the Open Doors program. Just a couple of housekeeping things. You all can ask questions a couple of different ways. You can type a question into the question box, or you can raise your hand. You should have a toolbar on the side of your screen that would let you, it looks like a little hand. So if you click that, that raises your hand, and then I would be able to unmute you. And so you could ask your question aloud if you prefer to do it that way. My style is such that I like questions. I'm fine with answering questions whenever. But if it's a typed question, I might just wait till there's sort of a natural break in the conversation or the raised hand. So, but feel free to ask questions throughout. So again, I'm Suzanne de Beaumont. I'm actually the project director for the Open Doors program. And how we're funded is through a program, a federal program called Money Follows the Person, or MFP. And that program was created or was offered to any state that was spending more money on institutional care than on home and community-based services. And New York was one of those states, and we applied and were given this grant quite a few years ago. And the focus is really on rebalancing that spending so that the states would spend more in the community than on institutional care. And New York has tipped that balance, and we now do spend more in the community, which is great. And who we are, I work for the New York Association on Independent Living, and we are the statewide provider association for independent living centers. And if you aren't already familiar with independent living centers, they're great local organizations that are run by and for people with disabilities, doing a number of services, everything from benefits advisement to information and referral. And the focus really is helping people with disabilities live independently in the community. And in that role, we've been helping people transition out of nursing homes for a very long time. So when this request for proposal came up, it was really a natural fit for us. And so in January of 2015, we were awarded the contract to provide the Open Doors program, which is the Money Follows the Person program in New York State. And we have been identified as the local contact agency. So if anyone is familiar with the MDS, the minimum data set has section Q, and that's if somebody answers yes to section Q, which asks, are you interested in returning to the community or interested in receiving information about returning to the community? If the person answers yes, then the MDS indicates that you're supposed to make a referral to the local contact agency. So that's us. And there's two components to Open Doors. We have both a transition center and a peer outreach and referral program. I'll talk a little bit about both. So the transition center, the main focus of the transition center is to assist individuals in nursing homes return to the community. And it is very person-centered and based on what the individual wants. And how we are structured is that we are set up in 9 regions across the state. And so we have independent living centers in each of these 9 regions that accept referrals from all the local nursing homes. And then we also have independent living centers, smaller independent living centers spread throughout the region. So we have a total of 24 independent living centers across the state. And the reason that it was so important to us to have so many of them is because we feel that it's important that the transition specialist, the individual who's working with the person who's in the nursing home, really knows the local services and supports and is from that area. So that's why it's spread out. And then here at NYAIL, we have myself, I'm the project director. We have 2 transition specialist liaisons to help train and support the transition specialists on the ground. We also have a nurse, but because what we found is that a lot of the individuals we're serving have complex medical needs, and we want to make sure that the transition plans that we're putting in place meet those needs. And we also have a social worker. We find that sometimes the barrier to someone transitioning into the community has more to do with, say, a family member who has concerns about their, mother, father, child returning to the community because something negative has happened, and it's really about supporting that individual and making sure they're comfortable with the transition as well. So as I said before, we are the local contact agency for Section Q. So a lot of our referrals come from nursing homes when the nursing home social workers ask the individual, are you interested in receiving information about returning to the community? We also, however, get referrals directly from discharge planners. So if you're doing a level 2 and you're recommending that the individual return to the community, or you're recommending that the individual would be able to live in the community, a discharge planner can send a referral at any time. In addition to working with the Department of Health, we also work with OPWD, the Office for Persons with Developmental Disabilities, and for the nursing homes, it's important for them to understand that as well, because there are some individuals in the nursing home who, have a developmental disability, may or may not be connected up with the state program that serves those individuals, but we can help get them connected, get made eligible, and receive services from them. People call themselves a lot and refer, and that's fine. We actually really like that. It's a good sign of if somebody is ready to transition, if they're actually making the phone call themselves. We get referrals from family members. We work a lot with the NHDD and TBI waivers, so we'll get referrals from the RRDCs in the NHDD and TBI waivers, and we also have been working a lot more with the MLTC plans, with the managed long-term care plans, and we'll get referrals from them as well. So what does, I keep saying the phrase transition specialist, I never really told you what we do. So the transition specialist, what they do is they start off by meeting with the individual and with anyone else that individual wants to be there. So, they can have their family member there if they want, their neighbor, their friend, whatever, whoever they want to have listen to what we have to say. And the first thing that we're trying to do is give the individual a real sense of what's available. I think that most people who are in nursing homes aren't aware of just the myriad of services that are available in New York State, whether it's waivers, whether it's OMH services or supported housing, whether it's MLTC services, all those different kinds of services that are available, I don't think most people are aware of. So we start off by trying to give them a sense of what is available and ask them, what are their needs? What's got them stuck? Why is it they're here even though they want to be home? So, some of the common things that we hear are things like, I've lost my apartment, I don't have a place to live, or, I need help showering, I need help in the home, those sorts of things. So, it's our role to give them enough information so that they can make a decision about whether they're interested in pursuing a transition back to the community. If they say that they're interested in returning to community, then our role really becomes connecting them up with all those different services and supports and helping them transition into the community. And how we do that is that we work very closely with the discharge planners in the nursing homes, with the care managers in the managed long-term care plans. We work with service coordinators in the waivers. And again, we're really trying to figure out what is the barrier, what is the reason the person is there. But what we found is that I think of them as sort of as the easier people, the people who already have a place to go and that there's no reason they can't return to their home. The nursing home discharge planners do a great job of setting up services and getting those folks home. So the people that we serve tend to be those folks that have some sort of problem. There's something in the way. And those are the ones that we tend to work with much more, rather than the say someone who broke their hip and is in the nursing home for a couple of months doing rehab. We also do something called community preparedness education. And what that is preparing the individual for day one. So if you think about being in the nursing home, perhaps you've had an accident or an illness or something, maybe you've had a stroke, and now let's say you use a wheelchair and you're not going to be driving a car. So it might be helping them understand how to use paratransit, public transportation, whereas it was nothing that they've used before. We also follow up after the transition. We do quality of life surveys, which have consistently shown that people have a better quality of life living in the community than in the nursing home. But that follow-up is really important, particularly, I would say, in the first month after a person leaves the nursing home, because as much as we really do try hard to have a good transition plan and get them everything that they're going to need, there's always times when the best laid plans don't go so well. And having somebody there to figure out, okay, well, what's not working, and maybe we need to get more of this, less of that, but just trying to resolve any kinds of issues that are happening with the plan that was put in place. So I see a question. Money is a huge barrier to people returning home. Do you pay for overcoming barriers? So that's a really good question. There was, one of the reasons that we changed our name from Money Follows the Person to Open Doors was because, a lot of people were saying, well, where's the money? Why is the money not following me? And our program itself is not focused on actually paying for things, but knowing what the resources are to pay for whatever it is they need. So the example that that the person is giving is, what if someone needed a wheelchair ramp, for example? So that's a great example of something that we would help with. So there's a number of different ways to get a wheelchair ramp. If the person is Medicaid eligible, then they can use MLTC. MLTC can pay for wheelchair ramps. If they are eligible for either the NHTD, Nursing Home Transition and Diversion Waiver, or the TBI waiver, they also have EMODs. If they're, depending on what county they're in, there's a program called Access to Home that can pay for wheelchair ramps. If they are a veteran, veterans can pay for wheelchair ramps. And depending, again, what region you're in, what area you're in, there are some CDBG grants, community development block grants, that will pay for ramps. And there are also local community providers that will sometimes build a ramp for people. So it is very kind of specific to the individual, but you can hear how there's no one answer. It's really working with that person, knowing what their circumstance is, so you can match them. If that's something they need, then almost always we can find a path to get a wheelchair ramp. That's a really kind of common thing. And somebody else just asked, do we work in the Buffalo, Niagara Falls, and Erie region? And the answer is we're statewide. So we work in all areas of the state. And then I have Melvina Smith has a question. So I'm unmuting you, Melvina, if you want to ask your question.
Can you hear me?
Yes, I can hear you.
Oh, wow. Okay. Because I had to switch from my phone. So I was just wondering, I may be, I may be asking this question prior. Sorry, that's my puppy. But have you had any success with placement of persons with Alzheimer's dementia?
Yes.
Who may have been inside of a facility for quite some time?
Yes.
And needing and looking to transition. And if you have, what have been your placements? As far as you're talking about outside of a skilled nursing facility?
So it all depends on what level of dementia they have and what kind of informal supports they have, what kind of family supports they have. So if the individual is able to direct their own care, meaning they can tell the aide, I need this, I need that, that's what I call direct your own care. They could be on NHTD, the Nursing Home Transition Diversion Waiver. That specifically supports individuals who have cognitive limitations. They'll give you something called HCSS, Home and Community Support Services, which is regular aid services, regular PCA services, plus something called oversight and supervision. If it's somebody who has it's much, much better when they have informal supports, or much easier when they have informal supports, because what's usually required is some kind of backup plan. What happens if the aide doesn't show up? If it's someone who has severe dementia, what I think of as can't direct their own care, if you left them alone, they're not going to be able to say, oh, gee, I'm alone, I better call someone, right? They're not, they're really cognitively impaired. If there are no informal supports for that individual, it's really hard for us to do a transition plan. That's just the reality of it, that you've got to be able to either direct your own care or have somebody, some sort of informal support that can help with that.
So what you're saying is that in this situation, for those who have Alzheimer's dementia, you would also find housing. What type of housing would that be? Finding housing in the community? If, say, for instance,
Yes.
They've been there for maybe a year or two.
Yes.
There's been success with that?
Yes. So we use
individual apartment?
Yeah. Yes. That is primarily what we do, is do individual apartments. So we'll use, and I'll talk a little bit more about it later, but we use the Olmsted housing subsidy if finding housing that's affordable is an issue. So Olmsted is a housing subsidy that kind of mirrors Section 8, and it's available to individuals who are in nursing homes for more than 120 days and need housing in order to leave the nursing home, and the individual is required to pay 30% of their income towards their rent, and then the housing subsidy pays the remainder of the rent up to fair market rate. And the Olmsted also comes with a housing specialist, and the housing specialist will actually find the housing. If the person isn't eligible for Olmsted or doesn't want to use Olmsted, then the transition specialist can also help the person locate housing. So whether that's, looking on Craigslist or nyaccessiblehousing.gov or wherever that might be in their local community, we do that as well.
Thank you.
Does that answer your question?
Yes, that does answer my question, because I have an MLTC background, and placement for these individuals, particularly Alzheimer's dementia with disability, is almost unheard of. So that is one of the issues, like you said before, is even if they are transitioned back into the community, there are different levels of Alzheimer's dementia. However, the backup caregiver support always creates a problem where they're sort of, they can't get out, because in the event that there is no aid, and because aid services can be very, they come and sometimes they don't come, like how can they be managed in a community setting? So when you talk about Alzheimer's dementia, even though they might be at their, the first stage of it, the thought is that it's going to be a progression. So how do you manage that? Like, they're stage 1 and they're, semi-able to direct their care, but once they transition to stage 2, to stage 3, then they're back in the nursing home, or what happens then?
So we're big believers in choice. So that's the conversation we're going to have with the individual. And if the individual wants to transition out and they're able to transition out, then we're going to follow that direction. And does it happen that people end up back in nursing homes after some time? Yes, that does in fact happen. But, even if you said to me, well, the person's only going to be in the community for a year, if that's something that person values, then to us, that's worth doing it.
Right. You're absolutely right. Because this is my last question, I promise.
Okay.
I had an individual who was in a group setting. He was with NYAIL, and he was living at NYAIL for about 4, maybe 6 years. More psychiatric issues or whatever. And then he went on ECT, which prompted some cognitive issues. He was getting the whatever that is, convulsive therapy. So NYAIL is really a program, a housing program for individuals who need like light assistance. They're independent, sort of, kind of
program, I'm guessing.
Huh?
Is it OMH, I'm guessing?
I believe it is OMH. Yes, it is a part of your mental health. And so what happened to him is that he started to exhibit some cognitive decline. And one of the issues is that he couldn't do his, he had to be reminded to eat a certain type of diet, and he was insulin dependent, which he couldn't do it on his own. So at that point, NYAIL says, you know what, he's no longer independent, and we can't manage him at this facility. So they were looking to transfer him into a nursing facility. So at that point, your hands are sort of tied, because this has been his home for 8 years. And even though he had family support, the family was like, you know what, they couldn't manage him at home. So what happens in a situation like that? Because even though his cognitive abilities weren't that bad, there was no other alternative. And even though when I wrote up the assessment, I believe that he could stay there for quite some time. When they when it's at a point, especially in a group home setting, they can no longer maintain their level of independence, that's when they start talking skilled nursing facility.
Right. So insulin dependence is one of the things that we will talk about in the very, very first meeting, because our experience is that to live in the community, being able to do your own injections is very important. And if you can't do your own injections, we can use consumer directed, but doing consumer directed assumes a certain cognitive level. You have to be able to manage staff in order to do consumer directed. So if you can't do then you need a support person to do, an informal support to do the consumer directed. So, but yes, we do come across that. All right, so I'm going to mute you again, Melvina.
Thank you.
And Nancy has another question about she lives in a county with very few resources, and does that mean less services because we have fewer services overall? And yes, absolutely, that's true. There are some very rural counties that have one home care agency. And so that absolutely impacts. So we can't create services. The Department of Health is really interested in, we have a database that we track information, and they're very interested in hearing about barriers like that are more systemic in nature. So we do report back to them when there's an issue like that. And we also work with the trade program, and the trade program is a program that has assistive technology that, and some of the trade programs are actually the ILC themselves, the Independent Living Center itself, and they have equipment loan closets where they can borrow a walker or wheelchair, or try out a piece of technology, something more high tech, and see if that works for them before we ask the MLTC or whomever to pay for it. Or if it's an equipment loan closet, a lot of times we'll just get the extra walker from the equipment loan closet. So, a good example of that is if you have somebody who's got a chair lift, a stair lift, where they can sit on the chair and it rides them up the stairs. It's really nice to have two walkers, one at the bottom of the stairs and one at the top of the stairs. But a lot of times it's hard to get the insurance company to pay for two, so you get a second one from the equipment loan closet. So moving on, some of the home and community-based services, I've kind of talked a little bit about them in the context of what we're doing. As I said, we work a lot with the NHTD and the TBI waivers, as well as OPWDD managed care. And as I said, the Olmstead housing subsidy, I just want to let you know that in addition to the housing subsidy itself, so helping pay for rent and helping seek rent, they also have something called community transition services, which allows them to pay for first month's rent, security deposit, and what I think of as your essential household items. So if you're moving into a new apartment because you lost your apartment because you've been in a nursing home for a year, you probably don't have a bed, a pot, a plate, a kid, a fork, blankets, that kind of stuff. So they're able to purchase those sorts of things. And by the way, both NHTD and TBI also have CTS dollars available. So we look at the whole person and what all their needs are. We also work with the health homes. We use their care management services for individuals who, if you think about the MLTC care managers, a lot of the service that they provide is calling somebody on the phone. And if you have an individual who, if you called them on the phone and you said, so, how's it going? And the person says, good. Do you need anything? The person says, no. And so then the care manager gets off the phone and thinks all is well and all is good. But if you actually went to their house, you would see that there were dishes and garbage all over the kitchen. They hadn't had a shower in a week, right? And if someone was just there, they would see these things right away. And if you asked, well, what's going on? They would say, oh, well, there's been no AIDS for a week. So there's, when you've got a situation like that where it's important for someone to be sort of checking in and live and in person as opposed to on the phone, that's a lot of times when we use the health home care management services. We also use the HARPs, which are the specialized managed Medicaid product that has enhanced services for individuals with serious mental health issues. So they have employment supports, education supports, they have family engagement, and they have some enhanced crisis supports. We also use the SPOAs or SPAs, depending on what county you're in, to access not only the behavioral health services, but also things like supported housing for individuals who need that level of service. And always we use the local community service providers. So I have another, I'll try and read this, a long question. I work in an inpatient unit. Besides working for Ascend as an independent contractor, we have a patient who's been dumped here by the skilled nursing facility after living there for about 12 years. They said they will not take him back. He has a developmental disability, but does not belong in a SNF. He has TANF ID, but he's not through the front door. I'm working on getting an OPWD care coordination. Who can help him qualify for the front door? Can you guys help me once I get him a care coordinator? All right, so the short answer to this question is that technically the psychiatric, if you're talking about a psych center, it's not, you can't be funded in a psych center because it has more than 16 beds by Medicaid. But I would say just shoot me an email. My email is going to be at the bottom, and then we can talk with Department of Health if we would be able to help in this kind of situation. And then someone, I'm not sure what the question, it just says HARP, Health and Recovery Plan. So if I said something different than that, I apologize. So our peer program is, I think it's a pretty unique program. And what it is that they are individuals. We have individuals who were already in an institutional setting and now live in the community. So they've already gone through the transition process. And especially when you're talking about someone who is new to a disability, it can be really helpful to speak to another person with a disability to get sort of their real world experience and their real world ideas of how that's going to work. So I do not personally use a wheelchair, but I know, many of our peers use wheelchairs. And if I say to a person in a wheelchair, oh yes, paratransit, you can use paratransit, they have lifts, they have whatever. It's a different thing than if somebody who has actively uses paratransit goes and says to them, look, here's the deal. I know it says that you only have to give 24 hours notice, but you're better off if you call a week in advance. And, to the extent that you have it on a routine, and you better leave yourself an extra half hour. And, they can give the real world experience, and they can say things like, and these are the restaurants that are accessible. And there's that kind of level of information that a peer has that just can't come from a person who's not in the same situation. And in addition to using, trying to match people on, what type of disability they have, we try and match on how old they are. We try and match the peers as best we can. We also have peers that are veterans. Vets talk to vets in a different way than the rest of us. And we also have added family peers. As I said before, sometimes the issue is a family member has concerns. And speaking to another family member who's already gone through this and knows what it's like to have aid services, and how often do call-ins happen, and what should you do when that does happen. We found that having family members speak to family members can be very helpful. So the impact, what have we done? And actually, since I put together this this slide, I ran another report. So we've actually received over 10,000 referrals at this point, and helped transition over 2,500 people since January 2015, which is when we started. And we provided peer services to over 1,200 individuals. And of the people who met with a peer at least once, more than half of them wanted to meet again. So it's a pretty popular service once a person has met with a peer. So, how would you guys and we work together? So I have to tell you, we use your information. You guys go and you're reviewing all the medical documentation, all the treatment information, and you guys are the ones who are saying, if you feel like this person can live in the community, you're going to make that recommendation. And on the resident review, you are able to make that recommendation. And for resident reviews, when the individual came from a nursing home and then went to the hospital, you can make that recommendation that for community placement, even though they're going back to the nursing home. And I just put in here for you guys a sample of a PASRR that was done where the recommendation was made. So you can see there that they, put in the information about the Open Doors program, as well as where the referral could be made. We've actually done quite a bit of outreach to all the nursing homes. So I hope that all the nursing homes know that we exist, but it's still very helpful to have it here, because this the PASRR also goes to the individual, and the individual is always welcome to call themselves. Like I said, we get referrals from individuals, and if we know they've had a level 2, we will actually ask for a copy of that. We find that it provides us with an awful lot of information, both historical and also about what kind of support services and supports the individual is going to need in the community. And we are big believers in not reinventing the wheel. So if you guys have already done a bunch of work, we're going to say thank you very much and read it all and take advantage. So how would you make a referral? Referrals are really easy to make, or at least I feel like they are. We have a referral form on the website so that anyone can use a referral form, send it in. We accept them. You can call the local regional lead. You can email the referrals. You can call the 800 number. You can, we're not picky. We'll accept a referral any which way we can get them. And if you would like more information on MFP, this link that's on this slide, it's to a program through Public Health Live. And there might be some continuing education credits available if anyone's in need of them, like social workers. But it's about an hour-long webinar. It doesn't cost anything, and it just explains much more about Money Follows the Person and Olmstead and how that was all created. Does anybody have any questions? Sharon Hightower, it looks like you tried to ask a question, but I didn't get any meaningful words. So does Sharon, do you want me to, I'm trying to see. Sharon, do you want me to unmute you? No, it was answered, she says. Can we get a copy of the PowerPoint? It was really fast, and I'd like to go over it again. So, sure. I think Emily has a copy. Am I correct, Emily?
Yeah, we definitely, we will definitely send out a copy to all of you guys.
Mm-hmm. So this was fast. I could talk more. I could talk for hours.
It's a lot. I would like to say that I really appreciate this, and I hope those of you that are out there, you can see that, how there's such a partnership, that there can be between what we do and what they do. Just in terms of, really the goal of PASRR is to figure out what is the least restrictive environment for that person, and what do they need, and even if they do need to go to a nursing facility right now, what could get them back to the community. So there were just a few examples that kind of stuck out to me as I was listening, that I was just like, oh yeah, that's exactly the types of things that we're looking for on the level 2, when you're identifying things like, oh, they just need someone to help with their insulin, they just need a ramp. They need housing. Like, those are the types of things that if we can identify that on the level 2 end, then, like you said, why reinvent the wheel? We
Right.
can just come to you, and you guys can make it happen.
Yes, absolutely. And so I will just say a thank you to you guys on the phone or on the webinar, because we do appreciate it.
Yeah, I would say too, just I would personally love the opportunity just to continue to, have opportunities to pick your brain just on resources that exist in New York, and, just finding out things that you guys probably know about that we don't even know about yet.
Mm-hmm. So here's my contact information for Grace or for anyone else. And maybe, Emily, when you send out the PowerPoint, if you wouldn't mind just including my email on that. So I'm happy to get emails, or you can call, whatever's easier, if anybody has any additional questions.
Will do.
All right, so it looks like we've answered the questions, or I hope we have. So, oh, question coming. Hold on. It says, I live in a poor and rural county, which rural counties definitely offer their own special challenges. We've done a couple of creative things in rural counties. Getting aid services is particularly challenging in rural counties. So we've actually helped people, it's almost like dating, but meet someone else in the nursing home that is also looking to transition out. And if they choose to live together in the same home, a 2-bedroom home, it might be a little bit easier to get the aid services, because what we found is particularly challenging in the rural areas is the travel time. So somebody who only needs a couple hours a day of aid services, it's really hard to get an aide to be willing to travel out to a rural area. But if you have 2 people in the same home who both need aid services, it can be easier to get those services in place. But that's like one creative thing we've done in the rural areas to make it work. All right, here we go. So when I complete the level 2, how do I ask the questions that hint at returning home, which may get the person's hopes up when the services don't exist? So that's a good question. I personally am a big believer in honesty. So I think the way that I would phrase it to them is, this is a program where they will do anything and everything they can to try and get you home. And it certainly doesn't hurt if that's something that they're interested in, to work with us. But being honest with the person that the particular area where they live, does have, and most people, by the way, who live in these very rural areas know this already. You're not going to be telling them any kind of secret, but saying, that they're happy to work with you and try their absolute hardest to get you home, but it may not be able to happen in that particular region because of the lack of services. Emily, would you agree with that?
Yeah, I think that sounds fair. I mean, I look at, really as the contractor and doing the level 2 assessments, we encourage you guys not to really say, hey, this is definitely going to happen, or this is for sure going to be the outcome, because, there can be other factors that are at play. The biggest thing that we always look at is just, that we want from you is to just find out what's their preference, and what would they need, like, if it was an option. So, we kind of always have looked at it like, well, if only, this was available, because you never know. I mean, like,
right.
And, And you probably look at it the same way that I do, that, hey, if we start seeing, in this area of the state, there's a bunch of people that really just need this one thing.
Yep.
You never know. Like, that could drive policy.
Yep. And like I said, the folks that we work at Department of Health with at Department of Health are great. They really do want to know where there's systemic problems, and the reason they want to know, they're not just, kind of asking because they're curious. They really want to know. So if there is something that can be done to fix it, they want to do that. So if there are no further questions, I think we'll sign off for the evening. Thank you, Emily, and you'll send out the PowerPoint and my email to everyone on the line.
We sure will. Thank you so much.
All right. Thank you. Bye-bye.